What's up, y'all? Welcome to Prison to Promise, the podcast that brings you powerful conversations with people and programs paving the way from incarceration to liberation. I'm your host, Dr. Craig Waleed. Today I'm honored to be joined by Dr. Evan Ashkin. He's a physician and the visionary director behind the Formerly Incarcerated Transition, or FIT program at the University of North Carolina. Dr. Ashkin has dedicated his career to addressing health disparities and dismantling barriers that formerly incarcerated individuals face when returning to their communities. I think that's pretty dope, y'all. In this episode, we'll talk about what inspired him to launch the FIT program, how solitary confinement impacts long-term mental and physical health, and what changes are needed in our healthcare and justice systems to truly support reentry and recovery. Dr. Ashkin also shares his vision for expanding FIT's model and offers advice for medical professionals and advocates alike. You won't want to miss this insightful and solution-driven conversation. Let's get into it. Now let's go. Right on. I just want to jump right in, man. I'm really excited to have you here today. Um, One thing I think about is before I even moved to North Carolina, I think you were one of the first people I reached out to in North Carolina about the work that we do, so really excited. Again, thank you for being on the show. And for people who are listening, I just want to let folks know that Dr. Ashkin, and correct me if I'm wrong, but you're a family doctor and the founder of the UNC FIT program. And the FIT program, I always tell people about the FIT program, man, even though I'm not part of it, because I really love what you guys are doing. And the FIT program helps people coming home from prison get the medical care and support they need to stay healthy and rebuild their lives post incarceration. And Dr. Ashkin, what I know about you is that you've been a leader in the reentry healthcare space for quite some time. And with that leadership, you've been making sure that folks aren't left behind when they return to their community. So, again, just so glad to have you here, man. Thanks for being with me.
Well, thanks for having me, Craig, and thank you for all you do.
Oh man, it's a community effort, right?
Yes, it is.
Yeah, and I think only certain ones of us are really in it, and it takes a heart to really be in it. Others are just doing it for who knows what reasons, but love that you're here. So, just to start the conversation off, man, I'd like to ask you, like what inspired you to launch the FIT program or the formerly incarcerated transition program?
Well, so as you said, I'm a family doctor, and even though I'm based at UNC, almost all my work has been in federally qualified health center, which serves, marginalized, minoritized populations, and I work with people on health services. And to be honest, Craig, it's embarrassing how long it took me to start paying attention to the impact of incarceration on my patients,
Hmm.
how devastating it is to them and their families and communities. And but eventually I finally started paying attention. And
Hmm.
at that point, started asking more questions and um, had, enough trust with a number of my patients for them to disclose to me all the harms that being in the carceral system had had. And then I started asking, well, what was it like when you got out? Because I have patients with high blood pressure and diabetes and kidney problems and lung disease. And they were like, yeah, there was nothing. And it took me forever to get any services because sadly in our state, we didn't expand Medicaid. So almost everyone is uninsured when they get out and sort of uninsurable, right? Because the Affordable Care Act, Obamacare,
Hmm.
was written assumed that every state would expand Medicaid. So people are not eligible for the subsidies in Obamacare if you're, under 138% of the federal poverty limit, which is almost everyone coming out. So that's what inspired me to think, okay, this is ridiculous. I mean, and honestly, it wasn't even you had to convince people to care about the person. It just makes no sense fiscally. So even if you're just fiscal conservative, releasing someone with chronic medical problems, not connecting them to care, they are going to eventually wind up in an emergency room, get hospitalized, preventable complications, and at the end of the day, cost the taxpayer even more than if we had done the right thing in the first place. Now, I actually care about people's wellness. That's why I'm a family doc working in sort of public health sector. And then I looked around the country to find a model that seemed appropriate and that really was keyed into the fact that people with experience of incarceration are the experts, and that when I looked for something to try to do, I've been around a while. I don't know if people can see me on this or listening, but I'm 65. I've been around the block, and I know that people, in the ivory white tower of medicine don't know the answers. And, I love the statement, those closest to the solution are those closest to the problem.
Lynn E. Martin.
Yeah, all right, there you have it. Thank you. And so the FIT program is based on the Transitions Clinic Network model, which was started by these awesome folks out in the Bay Area, California, actually around 2006, 2008. And they were the ones who started the program of hiring people that are formerly incarcerated, training them as community health workers, and then embedding them in a primary care medical home, which mostly are these federally qualified health centers. And it's not rocket science. I know people like yourself, Craig, who have lived experience, and it's like, duh. It's like, of course, that's what's going to work. But unfortunately, we've had to study it over and over again to prove to people that this is the most effective model. And happily, it has now been well studied and been shown that when you enroll people in a FIT-like program, they have reduced hospitalizations, emergency room utilization, but really importantly, also fewer days incarcerated and fewer parole and probation violations, and gives them an opportunity to get their healthcare needs addressed before the wheels come off even more than they may have even while they were incarcerated. Because as you and many of your listeners know, the healthcare you get on the inside may be really, really inadequate to inadequate. It probably it
Yeah.
rarely goes above inadequate.
I wouldn't even call it health care. I just call it health attention.
Okay. Yeah, well, and language is important.
Yeah.
And I know that correctional officers are often the ones who are deciding whether you get health care in the first place or not, right? And that if you have a beef with the CO, I mean, I know that I've heard many, many stories of, people dying because the CO, thought they were BSing or they just had a beef and they weren't going to, get them health care.
Yeah. Yeah. And we know that COs are not medically trained. And I don't want to talk bad about those people who are doing the best that they can at that job. But yeah, I don't think they help at all when it comes to helping stabilize people or help people getting better.
Yeah. And, you bring up an important point because, when people throw the prison system under the bus about this, I mean, could the healthcare be better? Of course. But our society is what has decided to incarcerate mass numbers of people, disproportionately people of color and people who are poor, right? And then lock them up and then underfund the prisons, build the prisons in places where people don't want to live, where you can't get any healthcare services, right? And then, so when we focus on how the prison systems failed, I think we are missing the point about how much of us as a society we have failed, and we've just, you know, created these policies and then put the prison system as this safety net's the wrong word, but just as like our dumping ground is probably the better word.
Wow.
People that we've decided aren't valuable human beings, right? And then the healthcare system is inadequate. It's poorly funded and terrible living conditions, crowded. There's communicable disease like tuberculosis and HIV and sexually transmitted diseases and COVID during the pandemic. And we sort of miss the point when we just blame the prisons, right? Because it is a societal failure that has created this problem.
Yeah, and it's a cesspool of sorts where some of the sickest people in our communities and our societies, as you said, are just dumped, you know. But tell me this, Dr. Ashkin, what in your experience are maybe some of the most common and urgent health issues affecting people returning from incarceration?
Yeah, Craig. Well, I make probably too many sarcastic comments, but one is there's two crimes that over half the people are incarcerated for: the crime of mental illness, the crime of substance use disorder, right? Neither are crimes. And so I can tell you that in our state, 70% of the people have substance use disorder who are coming out. And somewhere, well, 20 to 25% have mental illness of some kind, and probably at least 10% severe mental illness. And then you could arguably state that everyone coming out has some type of post-traumatic disorder as a result of incarceration or the trauma that they experienced prior to incarceration. So those are super important needs that are often not addressed. And certainly, the prison system is woefully set up to try and provide adequate substance use disorder treatment and mental health, because that's intensive treatment. So that's a huge issue. But, the diabetes, the high blood pressure, and there's a concept that's gaining traction in medicine called allostatic load. And this is the impact of growing up in difficult environmental conditions, sociologic conditions, subjected to racism, over policing in your communities, and how that impacts your health. So, because there's this question, since race is a social construct, right? It's not a genetic reality. But we know, like, Black men have terrible health outcomes in this country. Well, why is that if it's not genetics? Well, I'm a white guy, by the way, if you're just listening and you can't see me. But I'm talking from my experience taking care of people of color.
Yeah.
And that it's a tremendous burden on your not only emotional self, but physical self. And actually, we know that it impacts genetics. There's something called epigenetics, where if you grow up exposed to like chronic systemic racism, genes will be flipped on and off, which can damage your health. And so I see a lot of folks coming out, not just people of color, but with very poorly controlled high blood pressure, diabetes, and they might have gotten that diagnosis while they were incarcerated, because sadly in our society, the only time you have a constitutional right to health care is during incarceration.
Isn't that something?
I mean, how crazy is that? So
It's knocking futs.
yes. So many people, because they came from, poor, marginalized communities that had inadequate health care in the first place, never got their diagnosis, got it in prison, probably didn't get much disease self-management, don't really maybe understand what diabetes and high blood pressure really are. So folks come out and they have other priorities, right? Housing, family reunification, and employment, some money in your pocket. So your diabetes, your high blood pressure falls to the wayside unless you're very fortunate to, have that assistance. And that's really honestly the difference with FIT from really most other programs, is that, we try to really focus on those other things, those housing, transportation, job readiness. But the big difference is our community health workers are embedded in a medical home where we pretty much guarantee they're going to get those services. We have awesome clinicians who we've done training with, and they understand much more about the experience of people in incarceration, and they want to do this work to be helpful. We cover the costs at their medical home if they are uninsured. So if you're in the FIT program and you go to a community health center, that's our partner, and you're uninsured, we'll cover the sliding scale fee to be seen, and medications. We can cover most of your medications as well. And that makes a huge difference. So that's another reason we've had good outcomes, is that our community health worker can really vouch for the clinic and for the provider and say, look, give them a chance. These folks are really here to help. They understand as much as they can. For people who haven't been incarcerated, what you've gone through, they're going to work with you. They're going to work together, with me as your community health worker, to really actualize a plan that makes sense, that's doable. And then, we'll get your health on track. But we also understand that, all these other things are super important priorities. So we'll try to help with, parole and probation issues and housing, transportation, et cetera.
And so when people are on your caseloads, or when you start working with people, how long are you working with them before, I guess you, for lack of a better term, drop them?
Never. So there's no time frame. And again, reentry, is not linear, as addiction isn't, and recovery is not linear, right? So I've patients in my FIT program I've been working with since we started in 2017.
Oh, wow.
And, some people, after 6, 9 months, they've got their job, they've got their health care, things aren't chaotic. And, they'll still be my patient because we certainly don't have them leave the clinic, but they may not need the services of the FIT program longer. So there really is no set time frame, Craig. We will work with people as long as they, want us to work with them.
Oh, that's wonderful, man. And so I hope that folks who are listening or who will listen to this interview can definitely funnel their people towards the FIT program who might be in need of some of your services. But you said something earlier, that really piqued me, and you talked about, the disproportionate number of Black and brown people, people of African American and Latino heritage and racism, et cetera, et cetera. And so just thinking about that, man, how does the FIT program address racial and economic health disparities amongst returning citizens, if it does it at all?
So, super important question. My main answer is we pay attention.
Mm,
So, a lot of reentry programs, unfortunately, and all kinds of, as you may know, this recovery courts, drug courts, diversion deflection actually have benefited people who are Caucasian much more than communities of color.
mhm,
So we really pay attention in the FIT program to like who are we enrolling? Are we doing outreach to the right places so we're not making that same mistake and disproportionately advantaging um, folks who get referred, which are much more often Caucasian. So, and as you may know, in North Carolina, about half the folks in our prison population are Black, even
mhm.
though our state is only 21% Black. So I can tell you that we actually serve more than 50% of the people in the FIT program are Black. So we pay attention to our statewide numbers. By the way, we're in 8 counties now, hopefully soon to be 10. And we pay attention by county and by statewide. How are we doing? Look at that and really try to make sure that we are reaching out to the appropriate community members so that we are not making that same mistake. So that's one way we try to address the racial equities, racial inequities. And then the other thing is our role as advocacy is really, we try to, at every opportunity we can, talk about these issues around the state to county commissioners, to people in the medical field. We present at medical conferences and to the administrative office of the courts and try to do a lot of training to make it more visible, what people are facing coming out of incarceration, and then all the inherent bias, stigma, and structural racism that keep perpetuating harms to communities of color.
Yeah. Wow, man. I just had to breathe for a minute with that, just to let it sink in. It's really heavy when you take into consideration all of that, which you just mentioned. Um, And thinking about health, one of the things we don't talk about often, most people, should I say, outside of people who are working in the field, we don't think about mental health. I know it's a big buzzword right now. A lot of attention is being paid to the mental health condition of people. But how about when it comes to like solitary confinement and mental health? Like, research shows that prolonged solitary confinement or just prolonged trauma and exposure to trauma leads to severe physical and mental health issues. I'm wondering if you have observed this in the FIT program or amongst FIT participants who have been impacted by their time in solitary confinement psychologically, emotionally.
Yeah. Yes. So, and as you alluded to, Craig, and I know both of our heroes, Lauren Brinkley Rubenstein, has
She's
published on the increased suicide rate of
Mhm,
people post-release who were subjected to solitary confinement.
mhm,
So yes, I mean I see this all the time. Actually, our community health workers who have experienced solitary, have told me many of their stories about the harm. And as you stated, we know that it probably in and of itself causes traumatic brain injury to be in solitary confinement. And then no huge surprise, one of the sad stories that's repeated over and over again is somebody is incarcerated really again because they have psychotic mental illness issues, right? So they're off their meds, they're on the street because we have such a failed mental health system, And, they're creating public disturbance, right? Because they're off their meds. They got all their stuff in a bag. Maybe they're somewhat paranoid, being aggressive. The sheriff's called, right? So where are you taken? Not to mental health treatment, but
Right.
to the jail,
Right.
which is not set up to provide those services. So people are difficult in the general population, right? Because they're psychotic. It's
Right.
not their fault, right? And so where do they get put? In solitary. And it's very difficult to make people take their meds. So oftentimes they stay in solitary, psychotic off their meds. And that we believe in and of itself is a form of torture and causes further injury and harm. And this has not been well studied. So I can't say, oh yeah, according to, this study of 5,000 people, blah, blah, blah. But I think, as you know, and I think most of us who are in this field have seen, is that people with serious mental illness who have that experience are incredibly fearful, mistrustful, have understandable anger and some paranoia then about any medical services. My experience is they are much less likely to go to referral when I want them to get psychiatric services, try to get back on meds, or they feel like they were over medicated during incarceration if they got on meds and didn't like that. So it's very tricky. And so one of the things we actually do, we have part of the FIT program, which is specifically for people with serious mental illness.
Oh, wow.
It's called Fit Wellness, and we were very fortunate to get a pretty significant investment from the state under our previous governor, Cooper's action. He set aside almost $100 million to take care of people with mental illness coming out of our prison system.
That's great.
Yeah. And Governor Stein has continued commitment to that work. And actually, First Lady Anna Stein is a real champion for this work as well. So the FIT program, we actually we received $5.5 million to expand the work we do with people with serious mental illness. And that funding has allowed us to be able to like meet people as they're on the way out the door, put a phone in their hand with minutes, put them in emergency housing if they need that, get them clothing, food, and then have a community health worker specifically dedicated to working with them. And an amazing psychiatrist, Dr. Ted Zarzar, has been our lead on this, who also works inside the system, but is a community psychiatrist. And actually, we're doing what I think is the first thing done in the country is really continuity psychiatry from inside to outside. So if Dr. Zarzar didn't work with them on the inside as their psychiatrist, he's able to access their records. And we then provide this, quite comprehensive care because not only will they see Dr. Zarzar, and now we're in Wake, Orange, Durham, and New Hanover counties, they'll also see a family doc at the same time.
Wow.
So they're getting real, what we co-located care. So they're getting their diabetes and high blood pressure addressed by the family doc, but they're seeing the psychiatrist at the same time, making sure they're getting the right psychiatric treatment. And then we're in the process of hiring a therapist for this program as well, so we can do more counseling. And it's early, but our outcomes at this point are incredibly positive.
Mhm.
But we're only able to touch, even with that funding, a small number of the people coming out because so many folks really could benefit from this.
Yeah. 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 It's better to be able to reach a few than none at all, right?
I mean, it is heartbreaking how the gratitude that people show having this assistance it's really something. And I wish that many people who don't think that this is helpful or that we should be spending money on this kind of human service could be there in the room and just see what a difference it makes, and for that person to feel valued, to feel like they're treated as a human again,
But they're heard
and
and seen.
and then to, when we're seeing greatly improved outcomes.
Yeah, I can only imagine because you're giving that great attention. As you mentioned earlier, we pay attention. We're hearing them, we're seeing them, we're addressing their needs. And so, like, aside from what the FIT program's doing, do you have any ideas about how maybe um, others in the medical community could maybe respond to long-term health effects of solitary or just incarceration in general.
Yeah. So one of the things we're also privileged to do in the FIT program is lead the North Carolina Technical Assistance Center, which is also funded by the Department of Health and Human Services, to help programs around the state that are interested in assisting people who are at risk of incarceration, actually an overdose.
Mhm.
So we've had an opportunity to sort of get our finger a little bit on the pulse of a number of, amazing folks around the state who are leaning into this work, who not just in the Reentry community, but also in the healthcare setting. And to the point of your question, Craig, there are a lot of folks who are now really thinking about this in ways that are um, informed by the experience of the people they're taking care of, instead of informed by maybe bias that we've had in the past about people who may be in the system. So a lot of the more the programs are using peers and are really understanding the value of peer support. I would say specifically for substance use disorder and mental illness, right? Which are, I think clearly both those issues matters a lot to somebody that they have a peer who has been formerly incarcerated and suffers from one of those disorders or both.
Mhm.
And there are many more programs that are doing that. And I think that's one thing that is really important, is that continue to grow, is having peers, embedded in many of these healthcare settings. Because, we know just for even just diabetes in and of itself, having a peer educator for any diabetic, whether they're, someone who's affluent and has a, strong educational background or not, is very, very powerful. So, yeah. So, and then another thing I think is that I'm really excited to see are these diversion and deflection programs,
Mhm.
or these law enforcement assisted diversion programs, right? So people with mental illness, substance use are not being sent to jail and prison in the first place,
Right.
right? So they're actually getting sent to treatment, which is that's what
We'll
folks
do
need.
better.
Yeah, so I think that's another really positive thing, again, that the state is really investing in.
Mhm.
The prison system is investing in that through their local reentry councils. And, there's been a strong, strong leadership in our prison system to promote improvement in reentry and funding it. We get direct funding from our state prison system to do the work that FIT does. And then our Department of Health and Human Services continues to prioritize, funding for people who have been impacted by the criminal legal system. So I think there's a lot that we're doing, which is, really on the leading edge nationally of trying to address some of the root cause issues that people wind up getting reincarcerated or having bad health outcomes.
Yeah, I'm just blown away by the FIT program. I always talk about the FIT program whenever I get a chance to. So I really love the stuff that you folks are doing there. And thinking about how you and the FIT program and UNC have taken the lead in many regards. Um, what do you think, like perhaps the role other medical schools and healthcare professionals can play in ensuring returning citizens receive proper care?
It's a great question. I think we have to start educating in our medical schools and all of our training systems so that people understand the context of mass incarceration, and for all allied health, right? Respiratory therapists, physical therapists. That's a big part, is destigmatizing, so that people, if you don't understand anything about the system, right? And you're a young doctor and someone's brought in and they're shackled in an orange jumpsuit and there's two guards with weapons,
Yeah.
you're going to think, oh my God, this is a terrible person that did a horrible
Yep.
thing. And
Yep.
God forbid they're a person of color, then all the racist stuff starts spinning in your head.
Yeah.
But that's, you and I know, that's how everybody is brought in. You
That,
know,
yeah.
you could be in there for whatever, but if you're brought in from prison or jail, you're going to be shackled, weapons, blah, blah, blah.
Right.
So when we don't teach about it, we perpetuate a lot of the harms, right? Because we're continuing the stigma. So honestly, I think education about the criminal legal system needs to be incorporated in, medical school and then all that postgraduate training. And we do participate in that. So I think that is really important, step number one. And then step number two is to understand what the limits are on care. Because as you probably know, when someone is brought in, they have a correctional officer with them the entire time. And when we don't understand the rights that a person has or doesn't have, the healthcare system is not probably doing their best by the patient, because we're doing what the correctional officer says you can and can't do, and it's oftentimes the truth, um, but it may not always be. And there are a lot of strict limitations, but I think we really owe it to our patients who are in the carceral system to know what the rules are. And we have worked actually with the state prison system and my colleagues in the emergency medicine department at UNC, actually at UNC, to create like an FAQ on what are what you can do on behalf of your patients and what you can't. Like, can you tell family members about like a future follow-up plan? Can't you? Are they allowed to visit? What's food and transportation, all these things that everyone is confused about and doesn't understand. So I think that's an important thing that we need to do too, is understand what kind of care and what kind of communication we can have.
And it's interesting that you mentioned educating physicians or people who are training to be physicians. And I say it's interesting only because several months ago I was invited out to Winston-Salem to speak to medical students at what is it, Wake Forest
Yeah,
University.
cool.
This group called Physicians for Human Rights, and I talked about the impact of incarceration on overall health. And so,
Great.
just having those young students reaching out and wanting to learn really said that, this is a promising, at least cohort of students, and maybe the next generation of doctors will be a bit more informed, you know. And so, last question, Evan, for you is, what, what are your biggest goals maybe for FIT in, say, the next 5 years?
More fit programs. It's really tough when someone says, "Oh my God, we want to be part of fit," and then they tell me where they live and we don't have a fit program there.
Yeah.
So, in the next 5 years, obviously, depending what the present federal administration does, um, we have this waiver that was approved, this 1115 waiver, which would allow Medicaid to be turned on 90 days before release from prison. So, what I'm really hoping, Craig, is that we'll get that operationalized, and basically many, many community health centers and around the state could hire community health workers with lived experience of incarceration. There would be then the fiscal ability to hire those folks because they could get paid by Medicaid to go into their local prisons, begin this in-reach process, create the connection prior to release, get their medical records, start a treatment plan, and then really have them teed up for success when they get out, because then they'll already sort of be part of that local community health center, where then they already have a trusted relationship with a community health worker with lived experience, get into care, seamless, warm transition. And ideally, I would hope that many of these would be fit programs and these FQHCs, but I'll take it not just, I would take it though if they're able to, do our model at least by hiring people with lived experience to do that work. I think that could really, really make a huge difference around our state, and then not limit the availability of this kind of opportunity for health to just where we have fully functioning fit programs.
That'd be amazing to see that spread out on a national level.
Yes.
And that's it for me. I guess the last thing, and then I can give you back your day. That is, if people want to get involved with FIT or if they want to reach out to you, how can they do that?
Yeah. So ncfitprogram.org. So hopefully that's pretty straightforward. ncfitprogram, one word, .org. And that'll take you to our website, and you can see then where we have our present programs, contact information for the community health workers there. We have resources and some links to hopefully some useful community resources. If you're so inspired, you could donate to help support the work that we do. And then there's email to reach out if you have more specific questions.
Right on, right on. And I'm gonna say, yo, thank you so much for your time. We'll call it a wrap.
Thank you, Craig. I appreciate the opportunity. I love what you're doing. I am really hopeful that we are making a difference all around the state with so many amazing partners and that we can continue to do a lot better, that we got a lot of work to do.
I think we are, Evan. It's all incremental, but it's getting there.
Great. Well, thank you, Craig. I appreciate
Right
the
on.
time.
Thank you so much. You be well, bro.
Bye.
Peace.
Hey, if you or someone you know would like to be a guest on the Prison to Promise podcast, please contact me at drcraigwaleed@gmail.com. I'll spell it out. That's DrCraigWaleE, as in Edward, D as in David, at gmail.com. Dr. Craig Waleed, DrCraigWaleed @gmail.com. Thanks for hanging out with us here on the Prison to Promise podcast. I look forward to hearing back from you. Peace.